I'm Dr. Rajiv Vora, foot and ankle surgeon from Amandeep Ujala Sickness Hospitals, and today I'm going to discuss foot and ankle examination. All of you know that foot is a very complex structure and it has so many bones, joints, and muscles, and lots of ligaments which actually provide stability to foot and ankle. So, examination of foot and ankle is not only a science but also is an art. In our clinics, the patients mostly present with the pain, swelling, and ecchymosis, which may be dependent on the area of the injury. And then the patient may complain of the various deformities which are seen. And some patients may come with the inability to put weight normally or painful weight bearing. And then they may have episodes of instability for which the patients report to our clinics, and some patients can come with callosities and the non-healing ulcers to our clinic. When I do the examination of the foot, I follow a very definite sequence, and this sequence starts with examination of the gait. The moment the patient enters the clinic, I just start looking how he walks. And I try to interpret his gait in both in the stance as well as in the swing phase. We are going to discuss gait in the lateral part of this presentation. After I have a look at the gait, then I start looking at the patient in a standing position from all the sides, from the front, from the back, from the medial as well as the lateral side. And then I observe his shoes or the footwear. If there is any wear, it gives you how the patient is walking and how he's loading his feet. So, footwear examination can give you the clue of the deformity and the complaints with the patients. Once the gait examination of the shoe as well as examination or observation in the standing position is over, I ask my patient to sit in a comfortable position. And normally this position is little higher than the examining person. And first, I start observing the patient in the sitting position and then palpate the various structures on the medial, anterior, lateral, and the posterior side of the ankle, and then in the midfoot and the forefoot region, and then, of course, the toes. Once I have palpated the structures, then I move towards appreciating the movements at the various joints and the strength of the muscles which are crossing the joints. Once this is done, then neurovascular examination, as in any other examination, is very important and it forms an essential part of the examination. After this is done, then I make a certain diagnosis in my mind, and then to prove the diagnosis, I proceed towards the special tests. For examination of the gait, we must understand the various phases of the normal gait cycle, and all of us know that it has got a stance phase and a swing phase. And in the stance phase, the heel strike, the flat foot, and the mid stance and the push off are very important. We should observe the foot in all these phases of the gait cycle, and only then we can appreciate what is happening to the foot. In the further slides, I am going to show a few common gaits which are seen in our clinic and how to interpret those gaits. Antalgic gait is a very common gait seen in the OPD, and it is compensation to avoid pain while the patient is walking. Any painful condition in the foot region commonly results in antalgic gait, and in this gait, the stance phase is shortened relative to the swing phase, and body leans or shifts weight away from the affected side. It is not uncommon to see patients with a foot drop in the clinic, and these patients present with high steppage and the slapping gait, which is compensatory mechanism to clear foot during the swing phase. In this patient, you see the leg and the hip are lifted unusually high when he is walking. And in certain cases, the patient may not be able to lift the legs sufficiently high and the toes may touch the ground. And when the foot hits the ground, a slapping sound may be produced. So that is why this gait is also called a slapping gait. And in foot drop patients, we need to appreciate this gait. It is equally important to appreciate whether the patient is walking in a pronation gait or a supination gait. In pronation gait, the foot rolls inwards on landing more than the normal and arch becomes flattened. If you have a look at the left side of the foot, you see the foot is getting rolled inwards as compared to the right side. Kindly appreciate this on the left side that the patient is having a pronation gait. And the supination gait is just opposite to the pronation gait where the foot rolls outward and the patient loads the outer edge. It is commonly associated with the high arch and the cavus deformity of the foot. If you look here, in both sides, the patient is loading particularly more on the left side. If you see the difference, the patient is loading more on the lateral side, and this is what is a supination gait. In our clinic, we may have to examine the cerebral palsy patients, and hemiplegia and diaplegia are most common presentations to our clinic in which the foot, the knee, and the hip may be involved, or there may be an isolated involvement of the foot. So, in these cases, we need to appreciate whether the foot is involved, the hip is involved, and the knee is involved, and what is the position of these three joints when the patient is walking. In Aquinas pattern, which is fairly common both in the spastic hemiplegia as well as the diplegia, the foot is in actually in Aquinas, and the remaining gait depends on whether you have a straight hip and knee, or you have an hyperextended knee, or you have a flexed hip and knee. And particularly in the crouch gait, you may have a little calcaneus when the patient is in stance phase. So it is very important to appreciate these gaits and realize whether it is a hemiplegia or the diaplegia. And I am going to present a few common cases of cerebral palsy where the gait can be interpreted. If you look at this patient has got a true equinus, and the patient is keeping the foot in equinus both in the swing as well as the stance phase, and this is suggestive of a contracture of gastrosoleus complex, and the patient can flex the knee while the patient is walking. While in the previous, gait we saw that the knee was in flexion, but here you see the knee has gone in hyperextension when the patient is walking. So we need to appreciate what is happening to the hip, knee, as well as the ankle at the same time. Crouch gait is mostly seen in diplegics, and in this, there is excessive dorsiflexion in the stance phase while the hip and the knees remain in flexion. And this is most commonly due to the ankle plantar muscle flexor insufficiency, which leads to disruption of the ankle plantar flexion and extension couple. And this is more common when you do tendoaxillary lengthening in the early stages in the diplegic patients. So I suggest it we should avoid early Achilles tendon lengthening in diplegic patients particularly, while in hemiplegic patients it may be a helpful procedure in cerebral palsy. Once I have finished with the gait analysis, then I move towards the inspection of the patient in standing position, and inspecting from the back gives you a fairly good assessment of the normal or abnormal alignment of the whole leg. Here you can appreciate, the varus at the level of the knee, and while the subtalar alignment appears normal. And in this patient, when the patient is standing, you see the left side is in fairly varus. So hindfoot alignment can be very well assessed from the back in the standing position. And in this patient, the hindfoot is in valgus. It is not only the hind foot which you can examine or assess in the standing position, you can also assess the forefoot. Then the forefoot get abducted, then you will see the too many toes sign, which is commonly seen in the adult flat foot or the adolescent flat foot. And then the lateral outer border may be convex where the foot is adducted, and you can see the toes on the inner side. So inspecting from the back, you get an overview of the alignment of the hind foot, as well as you can assess adduction as well as the abduction deformities of the midfoot and the forefoot. Once the inspection from the back side is done, then I ask the patient to face towards me so that I can do the inspection from the front side. And in the front side, it is very easy to appreciate any genu varum or valgum and even the deformities at the ankle joint if it is present. If you see here, there is a valgus which is seen at the level of the ankle joint, and the medial malleoli are more prominent, as well as you can see the arch is flattened in this patient. This is another patient where you see what we call a peekaboo sign, which is representative of a subtle cavus. And when the patient is standing, you can see a little bit of heel on the inner side, and this is what we call as a peekaboo sign. We can also see the adductus deformities. This is the metatarsus adductus, which you are seeing in the midfoot and the forefoot. You can also assess these deformities. You see the concave inner border and the convex outer border. Apart from that, you can see the deformities in the forefoot region, as well as the deformities of the hallux as well as toes when you are inspecting the patient from the front. Now I move towards inspection from the sides, both from the medial side as well as the lateral side. When you're appreciating from the medial side, you can see the equinus deformity at the equinus level or the midfoot level, and you can also see the position of the longitudinal arch, which is exaggerated in a cavus foot and flattened in the adult or the adolescent flat foot. Then I move towards the lateral side and start inspecting from the lateral side, where you may see the overload of the lateral foot, and this is a callosity which is suggestive of lateral overload, which is commonly seen in cavus patients. And then I also proceed towards the Achilles tendon and see the contour of the Achilles tendon. And if you see here, there's a big defect here as compared to the other side, and this is suggestive of a Achilles tendon rupture. And the prominence here in the calcaneal tuberosity is suggestive of the insertional TA tendinopathy in this patient. As I mentioned earlier, that I like to see the footwear before I ask my patient to sit, and you see there is wear on the medial side in this side of the foot in overpronated foot, and this is a wear on the lateral side in the oversipinated foot. So you get an idea this patient is having a cavus right from the foot, and this patient is having a flat foot just by the footwear examination. After I have finished the observation of the gait and the patient in standing position, as well as observe the footwear, Then I ask my patient to sit at a comfortably high position so that I can do the inspection from all sides of the foot as well as palpation from all sides of the foot. Once the patient is sitting comfortably, then I start inspection from the front. And in the front, I try to notice the various deformities in the region of the ankle and the forefoot. And here you see the quinovarus deformity and then the valgus deformity. And here you can see the deformity of the toes, which can be, realized in inspection from the front. Then try to locate the swelling if it is present, where the swelling is located. In this case, the swelling is just above the ankle, and the patient had a syndesmotic injury. In this patient, the swelling is again in the ankle region but a little low, but this patient had a recurrent tumor. And if you see here, there is a diffuse swelling of the ankle, and this patient had an ankle arthritis. And here you see there is a swelling in the midfoot region, and this swelling is suggestive of a chronic neglected injury of the Lisfranc joint. Inspection from the medial side includes looking towards the arches of the foot and see if there is a cavus foot, there's a high arch or the flat arch. And in the early stages of the adult flat foot, you can see a swelling along the posteromedial aspect, which is just posterior to medial malleolus, which is suggestive of posterior tibial tendinitis. And then you can see the deformities of the hallux in the sagittal plane, and here you see that there is a flexion deformity at the MTP level, and in this case there is a flexion deformity at the IP level of the hallux. Then you can also appreciate the equinus position in this leg, that after post-traumatic condition this patient had an equinus position which needed a further correction by revision orthodesis. And this is a case where you see a medial swelling at the MTP level, and this patient turned out to be a case of recurrent pigmented villonodular synovitis. So from the medial side, you look at the arch, you look at the deformity of the toes and the swellings wherever it is present. We all know that the lateral side is very notorious for injuries to the various ligaments, and the swelling and the ecchymosis in a particular area point towards a specific ligamentous injury. In this case, the patient had a swelling and ecchymosis in the region of the lateral ligament, so this patient ultimately had a lateral ligament injury. In this patient, there was an injury to the midfoot region, and you see the swelling is more in the midfoot region as compared to this ankle swelling. And this patient, the swelling was at the level of the base of the fifth metatarsal, and this patient had a fracture of the base of the fifth metatarsal. Then, after seeing the injuries on the lateral side in relation to the ligaments, then I divert my attention towards the peroneal tendons, and any swelling along the peroneal tendons may be suggestive of peroneal tendon tenosynovitis. And in certain cases, you find that these are more prominent, the tendons are more prominent, and this prominence is suggestive of a peroneal spastic foot. And this patient had a tarsal collision with a peroneal spastic foot. And then I pay my attention to the lateral border, and you see a callosity here which is suggestive of a lateral overload in this patient. While examining the patient from the posterior side, I divert my attention towards the pathologies of the tendo Achilles. And in this patient, if you see, there is a broadening of the heel and the pump bumps which are suggestive of insertional tear tendinopathy. Here you see there is a big defect in the tendoachilles just above the calcaneus, and the contour of the tendoachilles is lost, and this patient had a tear rupture, and the patient may come to you with surgeries done due to tendoachilles pathologies, and you can see the incisions and the leftovers after the surgeries and the infections also. Then I try to look at the alignment of the heel when inspecting from the posterior side, but it is better to judge the alignment in the standing position, which we have discussed in the previous slides. The inspection of the foot is not complete if we have not examined the plantar size. And if you look on anakymosis on the plantar aspect of the foot, it is suggestive of the Lisfranc or the midfoot injuries, which are often neglected. And this plantar ecchymosis is the sign which suggests that the surgeon should look into these injuries. Then you can have some idea about the alignment of the foot as well as the forefoot while inspecting from the plantar side, and you can also have some idea about the toe deformities if they are present. Apart from that, examination of the plantar side is very important to look for the prominence of the metatarsal heads, and if there are any keratosis or there is any callosity present which suggest an overload in the region of the metatarsal head, and it may be present in the patients who present with metatarsalgia. After finishing the inspection, I start palpating the foot, and palpation is the key to precisely diagnose the various conditions of the foot and ankle and appreciating tenderness in the various structures of the foot. A systematic examination of the foot and the ankle is required, where you palpate the different areas and then work towards the correct diagnosis. Most of the time, I start my palpation from the lateral side, and we all know that there are a lot of structures on the lateral side which are commonly injured, and many sports person or even ladies, they present with the twisting histories, and in the twisting histories you can find a lot of different structures which get injured on the lateral side, which include the ATFL, the CFL, and then the peroneal tendons. You may have a lateral malleolus fracture, even the sural nerve can get stretched. You can have an anterior process of the calcaneus fracture and the fifth metatarsal fracture. So all these things need to be appreciated when we are palpating from the lateral side. And in an unresolved ankle sprain where the patient had sprained for sometimes 6 months earlier or 1 year earlier and continue to have the pain, you have to really palpate the individual structure to reach the correct diagnosis. And we have published one paper on this where the correct palpation can help you to reach the correct diagnosis, and it is suggested to read this paper to help you to reach to the correct diagnosis in the lateral ankle pain. Examination on the lateral side, if you see here, this is the fibula and this is the lateral malleolus which I have marked. So what I routinely do is I start my examination from one side and then move towards the other side. If this is where the syndesmotic ligaments are. If the patient is having a tenderness in this region, that is between the tibia and the fibula, it is indicative of a syndesmotic lesion or a high ankle sprain. As we move down, now this is the space where I'm entering
between the tibia and the fibula, which means that it is the lateral gutter. So anything in this region, if there's any pain, the pain may be due to any osteochondral lesion, it may be due to anterolateral impingement or some fracture which has been missed. As I move down, now I move towards the attachment of the ATFL. The tenderness here is indicative of the anterior talofibular part of the lateral ligament. And here you see, this is the what you see is the attachment of the ATFL. So the injury to the ATFL, the patient will be tender here. As we move more posteriorly, there will be tenderness. If the tenderness is here, this is the attachment of the calcaneofibular ligament. And if the pain is here, then it is the pathology lies in the calcaneofibular ligament. As we move forward, backward, we see the peroneal tendons are lying here. So any tenderness in this region is suggestive of a peroneal tendon pathology, if you see. If you remember, the sural nerve travels between the posterior part of the lateral malleolus and anterior to the tendo-achilles. This is the tendo-achilles I have marked. So anything, any tingling sensation in this region is indicative of sural nerve injury. Then as we move downwards, the calcaneofibular ligament runs from the fibula posteriorly towards the attachment to the calcaneus. And if you have a tenderness here, then it may be a hypertrophied peroneal tubercle or the tenosynovitis of the peroneal tendons at the level of the peroneal tubercle. So once we have gone around the perifibular region, then I move towards the sinus tarsi. So this is the place where actually the sinus tarsi is. So if there is tenderness here, the pain may be due to a subtalar arthritis here or a sinus tarsi syndrome or any sinus tarsi impingement which is seen here. So from the sinus tarsi, I move towards the anterior end of the calcaneus. So you can have a pressure here. If you put here, the tenderness here is indicative of the injury to the bifurcate ligament, the attachment or the fracture of the anterior process of the calcaneus. As we move forward, this is the calcaneocuboid joint. So anything which is coming here may be due to the calcaneocuboid fracture or the calcaneocuboid joint pathology. And if we consider this as the cuboid, then you may have a peroneal accessory peroneal bone, osperonium, and the tenderness in here is indicated of the any pathology in the osperonium or what we call as a POPS syndrome, that is painful osperoneal syndrome. So it may be, and as we move further downwards and distally, we feel the fifth metatarsal. So the fracture here can cause tenderness in the fifth metatarsals. So on the lateral side, you see I have examined all the structure which are possible causes of the pain in this region. And of course, if you have a tenderness in the calcaneus, it may be indicated of some tumor pathology or it may be indicated of some infection in this region. And then you can also feel the lateral border of the tendo-achilles from this side, but I'm going to discuss the tendo-achilles in from the posterior side. So with this I finish the examination on the lateral side.
From the lateral side, I move towards the anterior side of the ankle where I palpate for any tenderness or pain all along the ankle joint line anteriorly, and this may be present in the presence of pathologies like osteochondral lesion, any impingement or arthritis in these regions. Once the whole joint line has been examined for any tenderness, then I try to appreciate the tenderness along the tendons which are crossing anteriorly over the ankle joint, which include the tibialis anterior, extensor digitorum longus, and EHL for any tendonitis in this region. And finally, we know that there are nerves which are crossing, which may get untrapped or compressed. That is the superficial branch of the peroneal nerve, and you may appreciate some tingling sign in the presence of any compression of these nerves.
Now I'm showing the examination from the anterior aspect of the ankle. And as we move from lateral to medial, there are different structures which need to be identified and palpated. The first thing is that you see there is a syndesmotic ligaments which is connecting tibia and fibula, and in the syndesmotic injury you can find tenderness here. Then I start feeling the lateral gutter, which is between the fibula and the talus. Any any tenderness in this region may be present in chronic lateral instability or any anterolateral ankle impingement, or if there is an OCD which is located on the anterolateral dome of the talus. Then I start palpating along the joint to rule out any impingement, that is anterolateral impingement. Then on the anterior side, if there is anterior impingement or ankle arthritis, and then I reach the medial side to see if there is any tenderness in the medial gutter, and it is again suggestive of anteromedial impingement. Now, with anterior joint line examination and the impingement, now we have lots of structures which are crossing anteriorly across the ankle. One is the tibialis anterior, one is the EHL, and the other is the EDL. So you can just keep on palpating these tendons sequentially to rule out if there is any tenosynovitis related to these tendons. So, and as we move down, you can actually feel the talar dome, and if there is any talar dome tenderness, it may be suggestive of AVN of the talus, and the diffuse tenderness around the ankle, which is all along the ankle, is commonly suggestive of an osteoarthritis of the ankle.
After finishing the anterior joint examination of the ankle, then I move towards the medial side where I look if there is any tenderness in the medial malleolus, which may be due to any stress fracture or any infection or any neoplastic lesion in this region. And from here, the deltoid spans in the various directions towards the navicular, towards the spring ligament, and then towards the sustentaculum tali. Any tenderness in the deltoid may be suggestive of a deltoid injury, and there are different tendons which are crossing behind the medial malleolus, like tibialis posterior tendon, FDL, and FHL, and any tenderness along these tendons is suggestive of a tenosynovitis of these tendons. And we must not forget that the posterior tibial nerve, which is crossing here, may get compressed and leading to a symptom of the tarsal tunnel, and these symptoms may be sometimes confused with the plantar fasciitis and need to be distinguished whether the pain is due to the plantar fasciitis or due to the tarsal tunnel syndrome or to the compression of the Baxter nerve, which is the branch of the lateral plantar nerve and can be easily confused with the plantar fasciitis. So we need to appreciate actually where the tenderness is in these conditions. And after examining the tendons, then we move more distally to see if there is any tenderness in the navicular, which may be due to the accessory navicular or the Muller-Weiss disease, and then it may be due to arthritis of the navicular-cuneiform joint. And as we move distally, the pain may be originating from the first TMT joint joint, and all of these structures as joint on the medial side need to be palpated for any pain and tenderness.
Now I'm going to show the palpation on the medial side of the ankle. If you appreciate, this is the medial malleolus and this is the medial saphenous vein, which you can see. This is a fan-shaped structure which is deltoid, which is originating from the medial malleolus and going to the navicular, to the spring ligament, to the sustentaculum tali and to the talus. So I start palpating all these components of the deltoid. If there is any tenderness in this region, it is suggestive of a deltoid injury. And you can have tenderness in the medial malleolus due to any stress fracture or due to any disease like infection in this region. Once I have gone through palpated these the deltoid, then I start palpating the three tendons which are behind the medial malleolus. First is the tibialis posterior, then you feel the FDL and the FHL. If there is any tenosynovitis of these tendons, it can be appreciated here. And then just behind the medial malleolus here, if there's a tenderness here, it may be due to a tarsal tunnel syndrome. So as we move down, and it is, if there is tenderness in this region, it may be a compression of the Baxter's nerve, and this has to be differentiated from the plantar fasciitis, where the tenderness is on the medial tuberosity, on the plantar medial aspect, but due to compression of the Baxter nerve, the tenderness is little proximal. So you can differentiate between two. And then, of course, you are seeing on the posterior medial side, if there is any tenderness, it may be suggested of any posteromedial impingement. And then you can feel any tenderness in the region of the calcaneus if it is suggestive of any stress fracture or infection. As we move down, now we can see the navicular. And in the talonavicular joint, you may have a pain which is due to Muller-Weiss disease, the avascular necrosis of the navicular, and this is the navicular tuberosity. And if you have accessory navicular here, it can be painful. As we move down, we can look into the naviculo-cuneiform joint if there's any tenderness here, and the first TMT joint. So with this, you feel any tenderness, it may be suggestive of an injury on the instability or the arthritis of this joint. So with this, I finish the examination on the medial side.
From the medial side, I'd move towards the posterior side where my concentration is more towards the Achilles tendon, you see, and to recognize the pathologies along the Achilles tendon, particularly distinguishing between the insertional tendinopathy and the non-insertional tendinopathy, and to see if there is any defect in the tendon in this region. Of course, you can appreciate pain along the posteromedial side as well as the posterolateral side, which I have already discussed along the medial side as well as the lateral side. So from here, I'll be concentrating particularly on the tendon pathologies like insertional and the non-insertional tendinopathy, or any bursa which is present superficial to the tendon or deep to the tendon.
Now, from the medial side, I go all around the ankle, and from the medial side, I move towards the posterior side, where I see the most important landmark is the tendoachilles. So if there is tenderness, here at the level of the insertion of the tendon, it is indicative of a insertional TA tendinopathy. And if it is 5 to 7 centimeters proximal to the attachment of the tendon, then it is indicative of the non-insertional tendinopathy. And if you have pain here, so there is a enthesopathy or the insertional calcification which can cause the pain. The pain anterior to the tendon here is indicated more of a bursitis. And if you have a diffuse pain along the tendon here, it may be due to a posterior ankle impingement in these cases. And then you of course examine the calcaneus. If there is a tenderness, it may be suggestive of some stress fracture in this region, and special test for the stress fracture will come on. So on the posterior side, you can examine the TA and the paratendinous structures, and with this I complete the palpatory method for the ankle examination. I've gone all around the ankle to palpate the different structures. Towards the plantar side to appreciate the structures which can be responsible for the pain on the plantar side. This is the calcaneus. Any infection in the calcaneus, tumor of the calcaneus, or stress fracture of the calcaneus can cause the pain in the calcaneus. As we move towards the medial side, this is the typical region where the medial tuberosity of the calcaneus and the plantar fascia is attached to this, so it can be a pain due to plantar fascia. As we know, plantar fascia has got three bands: the medial, the lateral, as well as the central band. And then if there is tenderness a little anterior to the calcaneus, you may have a distal plantar fasciitis, and there may be inflammation of it. So plantar fasciitis, any pathology in the calcaneus, you can appreciate on the plantar examination. As we move downwards, sometimes you may have a pain or a nodule here which is suggestive of any plantar fibromatosis here, if you can present. And as we move distally, you can appreciate the MTP joints of all the great toe as well as all the toes, to appreciate if there is any tenderness in the regions in the MTP joint or not. So with this, I finish the plantar examination of the plantar structures. The other thing you can even see here is, if you want to feel on the lateral side, you can feel, once again the fifth metatarsal in this region. Now we move towards the midfoot. If we know here is the talus, if there is anything in the talus, there will be painful. This is the navicular. You may have a tender navicular due to tender your stress fractures or due to Muller-Weiss disease. And then here you may have accessory navicular, which can cause pain in the patient. As we move downwards, then this is the medial cuneiform, middle cuneiform, the lateral cuneiform. Any tenderness in these bones you can appreciate if there is pain. And then along the tarso-metatarsal region, if there's any injury in the Lisfranc region, that is first TMT, second, third, and fourth and fifth TMT, you can appreciate. And as we move downwards, you can appreciate any tenderness in the region of the MTP joints. Now I am going to demonstrate the movements of the various joints of the foot. I start with the ankle first, and I hold the calcaneus and take the ankle to the range of movements from dorsiflexion to plantar flexion, and this is the range of movements at the ankle joint. To check the movement at the subtalar joint, cup the calcaneus and support it with your forearm and dorsiflex the ankle to 90 degree to lock the talus into the ankle mortise, and then give varus and valgus test to see how much movement is happening, which is the movement at the subtalar joint. For midfoot joints, you just hold the firmly the hind foot. Hold the hind foot in position and you do the abduction and adduction movement. These movements are occurring at the Chopard joints. For the lateral column of the foot, again hold this and then invert, holding the fourth and fifth metatarsal, and you can appreciate the movement of the lateral column of the midfoot. And once you invert the or lock the heel, then this movement decreases, as you can appreciate. Again, bring your subtalar to the neutral and then try to pronate and supinate this joint, the Chopard joint, and this will give you the movement at the medial column. And again, if you supinate, and this movement decreases, so it shows that it is occurring at the midfoot level. Now I'm going to demonstrate the movements at the Lisfranc level. The midfoot is stabilized and you hold the forefoot and do the dorsiflexion and plantar flexion. This movement is occurring at the Lisfranc level, and you can even pronate and supinate to see how much movement is occurring at the Lisfranc level. From Lisfranc, I move more distally and then I start touching the movements at the big toe. So these are the movements at the big toe. Just hold the metatarsal and the proximal phalanx and then start moving. And these movements may be restricted in hallux rigidus or hallux valgus. And similarly, for the movement at the interphalangeal joint, hold the proximal phalanx of the big toe and then move the distal phalanx to check the movement at the interphalangeal joint. Similarly, you can do these joints to the check these movements at the lesser toes also, so that you have a complete idea the movements of the various joints of the foot. Now, for testing the muscles around the ankle, you ask the patient to plantar flex legato. So here you can see the calf is contracting and you can see the tendo Achilles. So here you can appreciate the function of the triceps suri in this patient. For inverters, for tibialis posterior, you ask the patient to plantar flex and then invert. Yes. Here you are testing the inverter, that is the posterior tibial tendon. And then you ask the patient to dorsiflex and then invert. And you see this tibialis anterior is taut. In this position, you are testing the tibialis anterior. Then for everters, what you have to do is you have to ask the patient to plantar flex and evert. So this is for everter weakness. You are testing the peroneal, and then you again dorsiflex and ask the patient to evert. So this is again, you can test the peroneal tendons. Then you ask the patient to dorsiflex and this is for the strength of the extensor, the extensors or the dorsiflexors of the ankle. And then you just hold the first metatarsal and ask the patient to extend the proximal phalanx or the toe. And here you can see that I am testing the EHL tendon. And similarly, you can test the remaining tendons of the EDB. So all the tendons you can examine, extensor digitorum longus, EHL, tibialis anterior, tibialis posterior, peroneal, and all the muscles you can examine. None of the examination is complete without neurovascular examination, and the dorsalis pedis is felt in the dorsum of the foot just at the level of the EHL in the midfoot level, and you can feel the dorsalis pedis. And tibialis posterior is felt just posterior to the medial malleolus between the FDL anteriorly and the FHL posteriorly. Now I am going to show the distribution of the various nerves which needs to be tested. The deep peroneal supplies this area between the two toes. Superficial nerve supplies this area, and the sural nerve supplies this area. So all these areas need to be tested for any loss of sensations. As we come to the medial side, the saphenous nerve supplies this area, and when we come to the plantar side, this area is supplied by the tibial nerve. This area, 3.5 toes area, is all supplied by the medial plantar nerve, and 1.5 toes area is supplied by the lateral plantar nerve. So we need to see all the sensations in this area by preferably by Simonson monofilament if we are seeing the patients of a diabetic neuropathy.
After finishing examination of the foot and ankle, you may not sometimes find any pathology in foot. So one should look at the proximal joints like hip and knee joint as well as spine to rule out the pathologies in these situations or in these locations, because the spinal pathology can be one of the major causes of the foot pain, and particularly when your clinical examination is inconclusive, the proximal joints as well as the spine has to be looked for. After finishing the examination, like palpation, inspection, and examination of the range of movements of the joints as well as the muscle power, you may reach at certain diagnosis. And in order to confirm that diagnosis, certain special tests may be required. And now I am going to discuss these special tests for the various pathologies of the foot and ankle. It is not uncommon for the patients to develop chronic ankle instability after lateral ligament injury, and this instability can be detected by two common tests, which are the anterior drawer test and the talar tilt test. In the anterior drawer test, we try to translate the talus anterior to the ankle joint, and this translation, if it is more than 5 millimeter or 3 millimeter more than the normal side, then the test is considered positive. And similarly, we try to tilt the talus in the ankle mortise, and if this tilting is more than 23 degrees or 10 degrees more than the normal side, then it is considered positive. And I must tell you that these tests are not always accurate and need to be compared with the other side. So the translation as well as the tilt need to be considered to be compared to the other side, because in some patients of the congenital laxity of the ligaments, these tests may be positive even if there is no pathology in the lateral ligament or there is no ankle instability.
I'm going to demonstrate the test for lateral ankle instability. That is the drawer test. So there are different ways of doing it. One is you just hold the leg firmly and the foot firmly and try to translate the foot anteriorly. So if you see or if you feel instability or anterior translation of the talus, then it is suggestive of lateral ankle instability. The other way is that you put your one thumb here at the joint line and then do the same maneuver, and you can actually appreciate how much talus is moving anterior to the tibia. So this is another way of doing this test. This test is basically done in slight plantar flexion and internal rotation, where the fibers of the ATFL become laxed and the instability becomes obvious. Now I am going to show the varus tilt test, which is mostly positive if calcaneofibular ligament is injured. You hold the leg firmly and the foot as well and place one finger below the lateral malleolus and dorsiflex uh, neutral position. You just bring the ankle to the neutral position and then start inversion. If there is marked instability in this position, it is suggestive of a positive varicose test, and this is mostly seen when calcaneofibular ligament is lax as well as injured.
It is extremely important to differentiate between the high ankle sprain and the low ankle sprain. The high ankle sprain is an injury to the syndesmotic ligaments, and this injury can create a long term dysfunction and requires a much longer time to recover, and in some cases, it may need immediate surgery. There are special tests which are positive both in the acute and the chronic injuries, and these tests need to be done to exclude any syndesmotic injury. And in the next few minutes, I am going to just demonstrate these tests to you.
For the syndesmotic injuries, one is the external rotation dorsiflexion test. If you hold like this and externally rotate as well as dorsiflex, if the patient have a pain here, that is suggestive of a syndesmotic injury. And the other thing which is common you can do is a compression. You do the compression at this level, and if the patient has pain at the level of the syndesmosis, it is suggestive of a syndesmotic injury. And then you can even translate the fibula anteriorly and posteriorly, and when you are translating the fibula anteriorly and posteriorly, then if the patient has a pain in the syndesmotic region, then you may have it may be suggestive of syndesmotic injury. And then you ask the patient to sit cross leg, which is called the cross leg sign. And if the patient experiences pain in this position, that is again suggestive of a syndesmotic injury.
It is not uncommon to see the medial instability, and it is often due to the deltoid injury, which may be associated with the ankle fractures, or it may be an isolated injury, and sometimes the ruptures of the deltoid are seen in the flat foot patients in the later stages. In deltoid injury, if you ask the patient to do the heel raise test, if you see in this patient on the left side, the heel inverts, which suggests that the posterior tibial tendon is working, but still the patient is having a medial instability. So if the patient can do a heel raise test but still has a pronation sort of a gait and medial prominence when the patient is standing, it is suggestive of a deltoid injury. The other test which you can do is just try to tilt the talus in the ankle mortise, and if you find there is an opening on the medial side, it may be suggestive of a deltoid injury. Pain on the anterior side of the ankle may be due to ankle impingements, which may be an anterior, anterolateral, or the anteromedial impingement. And these impingements may arise from the soft tissues, hypertrophied synovium, some osteophyte, and osteochondrulation in these regions. So, to appreciate these impingements, you need to dorsiflex the ankle and either dorsiflex in neutral position, in eversion, in inversion, and when you get pain in these regions, it is suggestive of impingement. Apart from that, you can confirm these impingements by palpations on the anterolateral side and as well on the anterior side as well as on the anteromedial side. Posterior ankle impingement is one of the common causes of the posterior ankle pain. In this condition, there are a number of the structures which get compressed between the tibia and the calcaneus during extreme plantar flexion, which is common in athletes, and the patient present with a posterior ankle pain. And in this condition, when you suddenly flex the ankle, plantar flex the ankle, and if you appreciate a pain on the patient appreciates a pain on the posterior aspect, it is suggestive of a posterior ankle impingement. Flatfoot is another common condition which is seen in foot and ankle clinics, and it is characterized by the loss of medial longitudinal arch. But actually, it is not only the loss of this arch, but it is combination of many pathologies which includes hindfoot valgus, midfoot forefoot abduction, forefoot varus, and ankle instability. And all these deformities or the pathologies need to be appreciated during clinical examination, and a few preceding slides are just referred to the examination of the flat foot. Find the heel valgus deformity in adult flatfoot. The patient is made to stand and then observed from the behind for the alignment of the hind foot. If the patient is asked to raise the heel, and in normal person you will see the heel will get inverted, but if the patient has diseased posterior tibial tendon and it is not competent, then the normal inversion is not possible on heel raise test. Here you see the right side, the inversion is possible, but on the left side, the inversion is not possible on the double heel raise test. The single heel raise test in other test to see if on raising the heel inverts or stays in the valgus. Apart from that, in single heel raise test, the patient may be able to do single heel raise, but if you ask the patient to repeatedly do the single heel raise, then after some time it is impossible or the patient cannot do the single heel raise. So in this patient, the posterior tibial tendon is incompetent and the patient may have pain. The other advantage of the single heel raise test is that you can see any midfoot break in while the patient is doing the single heel raise. When the hind foot goes into valgus, the first metatarsal drops. And when the patient is walking with hind foot valgus, to compensate that, the first metatarsal has to go up. And this leads to a forefoot varus or forefoot supination deformity, which can be seen obviously when the hind foot is brought into normal alignment. Whether this deformity is flexible or fixed, it can be seen by flexing the foot and the first ray into plantar flexion, and if the deformity gets corrected, it is the flexible forefoot varus deformity. As the flatfoot deformity progresses, there appears midfoot and forefoot abduction, which is due to the uncoverage of the talonavicular joint, which subsequently is due to incompetence of the spring ligament. And this deformity can be appreciated from the behind by too many toes sign. If you see on the right side only one or two toes are visible, but on the left side you see four toes are visible. So this reflects the forefoot midfoot abduction deformity. As I mentioned in the previous slide, that the midfoot and forefoot abduction is due to spring ligament incompetency, a special test which has been designed to check the competency of the spring ligament, which is a neutral heel push test in which the examiner holds the hind foot while applying abduction force to the medial border of the foot with the other hand, and if you see the translation which is more than normal, it may suggest an incompetency of the spring ligament. The medial instability is reflected by a loss of the medial longitudinal arch, and this medial instability can occur at the level of the talonavicular joint, navicular cuneiform joint, or the first TMT joint. How much arch has collapsed can also be appreciated by inserting a finger just below the medial longitudinal arch. This loss of arch is flexible or not can be appreciated by jack test, where you try to reform the arch by dorsiflexion of the big toe in a standing position, and if this arch reforms, that means this deformity is flexible. The first TMT instability can be appreciated by holding the lateral four toes like this and then rocking the first ray in the dorsal and the plantar direction, and the instability at the TMT joint can be appreciated, and this TMT instability can be compared with the normal side to see if the affected side has got more instability as compared or more movements as compared to the normal side. Subfibular impingement, talocalcaneal impingement, and deltoid insufficiency are other components of the flat foot deformity, and the impingements can be appreciated by tenderness in the perifibular and the subtalar region, and the medial instability due to combined deltoid and spring ligament inefficiency can be tested by testing the deltoid ligament and spring ligament, which I have already discussed, and the medial instability at the level of the ankle can be reflected by a valgus deformity seen in the ankle mortise in the normal AP or mortise view. After finishing the examination of the dull flat foot, I moved towards the examination of the cavus deformity, and the treatment of this deformity almost depends upon the flexibility of the deformity and the apex of the deformity. And to check the flexibility of the deformity, Coleman block test is commonly performed, where you place a block on the lateral side of the foot and let the first metatarsal fall to the ground and ask the patient to bear weight. And if this varus deformity gets corrected by placing this block, then the deformity is flexible. But some people suggest it is better to check the flexibility of the subtalar joint by placing the foot in slight plantar flexion and then manipulating the subtalar joint, which gives you a better understanding of the flexibility of the deformity. Now I move towards the special tests for the peroneal tendon disorders. The peroneal tendinitis and the tenosynovitis and tendinosis are the most common conditions, which are normally appreciated by peroneal compression test, where the peroneal tendons are compressed against the posterior fibula, and if the patient has pain in this region, then this test is positive. The other common pathology with the peroneal tendons is the instability of the peroneal tendons, and in these patients the peroneal tendons may dislocate anteriorly, and they are obvious sometimes, and people can even voluntarily dislocate their tendons in certain patients, and you can provoke this instability or the dislocation of the tendons by an ankle circumduction test.
Start, sir. I'm going to show you the test for peroneal tendon pathologies. First I'm going to show is the compression test, where you place your 3 or 4 fingers behind the lateral malleolus and just compress the peroneal tendons. Any tenderness in this region is suggestive of peroneal tendon pathology. And then you can use your thumb in this region where it can compress the peroneal tendons, and then again the tenderness is suggestive of peroneal tendon pathology. Then you trace the peroneal tendons distally along the lateral malleolus right up to the peroneal tubercle. Any pain or suggestion in or tenderness in this region is suggestive of peroneal tendinitis in this region. Then you ask your patient to dorsiflex and evert and do the circumduction in all the directions and look if there is any subluxation in this region. So subluxation can be done in both the directions to see if there is any peroneal subluxation or dislocation. Now I'm going to talk about Lisfranc joint injuries. All of you know that Lisfranc has 5 joints, tarsometatarsal joints, and any of them can injured or all of them can be injured at one time. So if you have a diffuse injury and you just stabilize the hind foot and the midfoot, and when you do the compression and if the patient has got a pain, then it may be reflective of a Lisfranc injuries. Then the adduction and abduction, these are the provocative tests which stress the Lisfranc joints, and if the patient has pain, the pain may be due to Lisfranc injury. The other is you hold the metatarsals and pronate this and well abducted. If this test is positive, then it may be indicative of the Lisfranc injury. Now we move towards the individual examination of the tarsal metatarsal joints. If you find a squeezing here first between the first and second ray at the level of the TMT joints, it may be reflective of an injury to the first and the second ray. And then you can hold the midfoot and try to displace the first metatarsal dorsally as well as ventrally. So once there is instability or pain at this joint, then the injury is probably located to the first TMT joint. The other test is a piano test where you hold the foot and midfoot tightly and just press the individual metatarsals downwards like a piano. So if you have a pain on the tarsometatarsal region, so you can individually see that which of the joint is affected. So you can test both as a whole TMT joint as well as an individual joint with these tests. Now I am going to demonstrate the test for hallux disorders, and we know the most common hallux disorders are the hallux valgus, hallux varus and hallux rigidus. In the hallux rigidus there is a painful range of movement, particularly the dorsiflexion, and you may have a tenderness at the near the metatarsal head, which is suggestive of an osteophyte which is common in the hallux rigidus. What you want to know in hallux rigidus is that is there any MTP arthritis present or not. For that we hold the metatarsal and the proximal phalanx and then apply an axial force, and if the patient experiences pain, it is reflecting the MTP arthritis, which we call as a MTP grind test. The other common condition which can affect the great toe is turf toe. Here there is an injury to the plantar plate of the first MTP joint. The patient may have a tenderness here and the dorsiflexion is increased in these cases. And in extreme cases, you may have an instability at the MTB joint, which can be checked by holding the first metatarsal with one hand and the proximal phalanx with other hand, and then translating the proximal phalanx anteriorly and posteriorly, just like a draw test to see if there is any instability. And apart from that, we must check the instability in the varus valgus plane, and if there is tenderness on the lateral side, it may be suggestive of the injury of the lateral collateral ligament, and here you may see an opening or tenderness which is reflective of a medial collateral ligament injury.
When we are treating lesser toe disorders, the two important things to be considered are the flexibility of the deformities of the lesser toes and whether the plantar plate is intact or not. For flexibility of the lesser toes, a push-up sign is used, and for the plantar plate integrity, commonly draw sign is used where the proximal phalanx is translated dorsally in relation to the metatarsal head, and this translation is graded according to the amount of the translation which we can achieve while performing this test. The other common tests used are plantar plate provocation test and plantar flexion test.
Assess the deformity or the flexibility of the deformities of the lesser toes. A push-up sign is
you see we can just
present.
flexible deformity.
You just press the metatarsal head, just and if your deformities of the lesser toes get corrected, it shows the deformity of the lesser toes are flexible. This is referred to as a push-up test. And this patient has got a crossover deformity of the second and third toes, and then you see we can just, they are flexible deformities. So to check the deformity, the flexibility of the toes, toe deformities, you need to check whether they are flexible or not. Now we are going to talk about the lesser toe disorders where you have a different deformities like claw toe, hammer toe, and then mallet toe. But the basic thing is that what you want to see is whether these deformities are flexible or rigid, and the second, if there is any instability at the MTP joint. So for instability at the MTP joint, there are different tests. One is the anterior draw test, where you hold the metatarsal with thumb and the index finger, and the proximal phalanx again with thumb and index finger of the other hand, and try to translate the proximal phalanx dorsally. So whatever the amount of the translation is, according to that you can grade the instability. Another test is called the plantar plate provocation test, where what you do is you again hold both the fingers like this and then just dorsiflex the proximal phalanx, which stretches the plantar plate on the plantar side and causes pain. This is called the plantar plate provocation test. Then the other test for the plantar plate is called the plantar flexion test. Again, the position is same, but what you do is you plantar flex the proximal phalanx, and if the patient experiences the pain, that is suggestive of a plantar plate pathology. And finally, when you see this, you see the alignment of the lesser toes, and if you have a dorsal instability, this parabola won't be symmetrical, so you may have one of the toes going on this direction, and this whole alignment is disturbed, which may be suggestive of an MTP instability.
None of the foot and ankle examination is complete without examining the gastrosoleus complex, and you have to look for the contracture of this complex by using Silvis test, where you see the dorsiflexion of the ankle in knee extended and flexed positions. The other thing which is to be noticed, if there is any rupture in the tendoachilles or not. Here you have a look at the resting tension where you put the patient prone, flex the knee, and assess the dorsiflexion at the ankle. In a normal patient, there is a slight plantar flexion of the foot in this position, but in a ruptured tendon, there is a dorsiflexion. If you see here, in this side, there's a rupture of the tendon, while on the other side, the tendon is intact. The second test, which is commonly performed, is a Thompson test, where you squeeze the calf of the patients and look for plantar flexion of the ankle. If you look on one side, on this side, you see the plantar flexion of the ankle is occurring while I am squeezing the calf, while the other side, that is on the left side, when I squeeze the calf, there is no plantar flexion possible. So it suggests there is injury on the left side of the patient, while the right side has no tendoachilles rupture.
I'm going to demonstrate silver skull test in this patient who is lying supine and the knee is in extension as well as the hip is in extension, and then I dorsiflex the ankle. Once the dorsiflexion is done, then I bend the knee to 90 degree and see how much dorsiflexion increases. If you see in this patient, there is 5 degree increase in the dorsiflexion, and when I come again in the extended position, the dorsiflexion decreases. So this is a silver skull test which demonstrates gastrocnemius is contracted in this patient. Now I'm going to demonstrate the test for Morton's neuroma, which normally occurs between the third and the fourth toes, and you start compressing in the plantar side of the interdigital space, and if the patient has pain, then it may be suggestive of a Morton's neuroma, and this you call as plantar compression test. Then the other test is thumb finger compression test, where you use both the thumb and finger to compress the or to pressurize the interdigital space which is affected, and if the patient has pain, it is suggestive of Morton's neuroma. And the other test is that you squeeze the all the metatarsals and place your finger or thumb under the affected interdigital space, and you may be able to appreciate a click which is called Mulder's click. The Mulder's click should not be confused with the Mulder sign, which is actually the paresthesias in the ball or the metatarsal head region.
Tarsal tunnel syndrome is another common condition which you can see in your clinic. And in this condition, when you tap just posterior to the medial malleolus in the region of the posterior tibial nerve, if a Tinel sign is positive, it is suggestive of tarsal tunnel syndrome. Another test, external rotation pronation test, where you externally rotate and pronate at the ankle, which stretches the medial structures and the posterior tibial nerve, and if there are tingling sensations or paresthesias or sensory symptoms along the branches of the posterior tibial nerve, it is suggestive of tarsal tunnel syndrome. Calcaneus squeeze test is performed for the calcaneus stress fractures, and the patients normally present with the pain along the medial and the lateral aspects of the calcaneus, which is posterior to the facet. And here you just squeeze the calcaneus between the two palms, and if the patient has a pain during this squeezing, it is suggestive of a calcaneus stress fracture. Dear friends, with this I finish foot and ankle examination, and I have tried to cover most important aspects of the foot and ankle examination, and I hope you enjoy and like this presentation or video, and if you like it you may share it with your friends or in your class or with your students or with your colleagues. Thank you so much for having spent time in going through this presentation.